So I'll talk about decision-making and surgery for spinal metastases. You'll see some of the similar slides from Dr. Bilski's talk, but it's probably pretty important to keep repeating these decision points because we do this every single day when we see a patient with spinal metastases. And we'll start off with a case example. This is a 65-year-old man with metastatic melanoma. The systemic disease is very well controlled. Patient had some mild back pain, no neurologic deficits, and presents with this MRI. And the MRI shows a fairly significant epidural disease that's circumferential around the spinal cord, causing cord compression. And if we could take a second, use the audience response system to punch in. This is a pretty comprehensive list of all the treatment options. What would people do for this patient to start the treatment? Great. So, wow, a lot of people picked separation surgery. So the word is out. And a lot of people picked radiation. So we'll talk about how we actually make that decision. How do we choose the radiation and what kind of surgery we recommend? But those are really the two major considerations here. Before we start talking about the actual decision-making, we'll talk about the goals of therapy. And as you heard in Dr. Bilski's talk, in patients with metastatic tumors, our goals are largely palliative. They have a systemic disease which has to be controlled with systemic therapy, and we're talking about a focal problem in their spine. So, as I was saying, the goals are palliative. We talked about neurologic function. The second goal is preservation or restoration of spinal stability, and if the spine is unstable, we can't emphasize enough, we have to actually make it stable by treating that with either instrumentation or cement. So restoration of spinal stability, that's the next one. Pain control in all these patients, of course, that improves their quality of life. And then finally, local tumor control, making sure that if we're treating a spinal tumor, it's not coming back anytime soon. And we do that largely with radiation, various forms of it, whether it's stereotactic or conventional. And as you saw in Dr. Bilski's talk, we really have plenty of options on how to treat these patients. And the three broad categories are systemic therapy, radiation therapy, and surgery. Systemic therapy is evolving every day. There are new targeted therapies that are really changing the survival in certain subpopulations of patients with cancer. So it's always a moving target when we talk about that. Radiation therapy has evolved over several decades, and we still offer conventional radiation to certain patients who we think are going to respond to conventional radiation. But we can also offer high doses of radiation that are delivered in a very focal fashion using image-guided radiation therapy, and you'll hear a lot about that tomorrow. And we can do that either as single fraction treatments or hyperfractionated in 3 or 5 fractions. And then we're also experimenting and developing brachytherapy treatments in order to further improve local tumor control for these patients. And then, of course, there are many surgical options. We have minimally invasive options that can include either decompression that's done in minimally invasive fashion, instrumented stabilization or cement augmentation, various approaches that can be anterior, posterior combination of approaches, and different ways of taking out these tumors, intralesional or en bloc. And just to show how this, the way of thinking about the spinal metastases has evolved, and it's really because of this integration. As a surgeon, we think about what are the systemic considerations, what are the radiation options for this patient, and it really has changed the way we treat these patients. So if we use this case example, this is somebody with a solitary renal metastasis at L3, no other systemic disease, mild back pain. This is a lytic tumor. So once again, thinking about the goals of therapy for this patient, these are the treatment options again. Slightly different case from what I presented earlier. Maybe we can use the audience response system for this case as well. Can we cue that? If you could take a second, punch it in. Slightly different case, very well local control, local problem, renal cell. No spinal cord compression. The patient does not have neurologic deficits. Mild back pain. Great. So a lot of people recommend IGRT, which is a terrific way to get tumor control. Some people recommend a kyphoplasty with radiation for pain control, and some recommended surgery, various types. And en-bloc spondylectomy has been a consideration for this type of patient. And as you saw on the Tomita scale that Dr. Bilski showed, this was something that was published in 2001, which is largely a surgical scale. If we look at this patient specifically, this is a moderately growing tumor, solitary metastasis. Our goal is local control. This would be somebody who's recommended for wide marginal excision of this tumor. And that's a pretty big operation. I don't know how many people have seen this, but these are beautiful pictures from Dr. Tamita's case series. Can we move that as well? Thanks, sorry. So yeah, that's what the type of surgery looks like. This is a front-back operation, very extensive resection. It takes a long time to do. The median time in this patient series was 15 hours, oftentimes split over the course of 2 days. Median EBL was 5 liters. So that's a really big undertaking for this type of patient. But the goal is local control, and that's long-term. So that's fair. And this is what the patient got when they came to spine clinic at our institution a few months ago. They had some mild back pain from a lytic tumor, so they underwent kyphoplasty, which resolved the back pain, and then single fraction SRS. And this patient is being followed radiographically and did not require any type of extensive intervention. And they're able to go on to systemic therapy without a long interruption. So how do we make these decisions, and how do we integrate all of these possibilities, the systemic, the radiation, the various options of radiation, and the various surgical considerations? It's the NOMS paradigm. It's the 4 things that we think about every time we see a patient with spinal metastasis. NOM stands for the neurologic, oncologic, mechanical, and systemic considerations. And so the neurologic and oncologic are made in concert in order to decide what kind of radiation the patient requires and whether they require surgery. Neurologic looks at the degree of epidural cord compression and whether the patient has myelopathy. The oncologic looks at primary tumor histology and trying to predict how responsive the tumor is going to be to either conventional radiation or systemic therapy. And then we look at mechanical instability. And mechanical instability is a separate surgical indication because no matter how sensitive the tumor is going to be to radiation, if the spine is unstable, it has to be stabilized, and we won't be able to do that with systemic therapy or radiation. And then we look at the patient as a whole, the systemic consideration, to make sure that whatever treatment we are going to suggest for the patient actually makes sense in their systemic disease, and that they can actually tolerate this. So this is the neurologic consideration. The epidural spinal cord compression scale provides a very convenient way to describe the degree, and this is really common language that can be used when talking about this. 0 is bone-only disease, 1 is mild epidural extension without cord compression, and these are low-grade epidural extension patients. And then we have high-grade epidural extension patients. These are patients that have cord compression or displacement. So these are the 2 divisions, low-grade ESCC and high-grade ESCC. When we talk about the oncologic consideration, we look at the primary tumor histology. And this is a table that was gathered by members of the Spine Oncology Study Group when they reviewed multiple publications that actually detailed histology-specific sensitivity to conventional radiation in the spine. And as you can see, tumors like lymphoma, seminoma, myeloma, and breast and prostate tend to respond fairly readily to conventionally fractionated radiation. And breast and prostate are really the exceptions in the solid tumor metastases, and all the other solid tumor metastases do not respond well to conventional radiation. And these are a few data points from various publications. These are the tumor control rates for breast cancer. The median response in one publication was 11 months, which is quite good, and a 2-year local control rate in another paper was 86%. So patients with breast cancer can do just fine with conventional radiation. On the other hand, patients with colorectal had much worse tumor control rates. The median response in these case series was 3 months or a 2-year local control of 30%. So this is clearly fairly poor tumor control, and we need to be able to do better. So we divide these tumor histologies into radiosensitive and radioresistant, and this is based on their sensitivity to conventional radiation. If we put the neurologic and the oncologic together, this is the plot that we get. Any patient with a radiosensitive tumor, regardless of the degree of epidural extension and cord compression, unless they're neurologically deteriorating before your eyes, they can fairly safely undergo conventional radiation. And here's an example of fairly significant epidural extension from multiple myeloma. And just 8 days after undergoing conventional radiation therapy, you can see that the epidural disease has resolved entirely. On the other hand, patients with the radioresistant tumors will not respond well to conventional radiation, and these are the patients that need stereotactic radiosurgery for tumor control. Here's an example of somebody who's able to undergo stereotactic radiosurgery in the upfront setting. This is somebody with low-grade ESCC, so no cord compression, secondary to a radioresistant tumor. And this is a renal cell metastasis after 24-gray single fraction treatment. The tumor shrunk completely, and we've been following this patient radiographically, and the patient never needed surgery. You'll see these data tomorrow, so I won't spend too much time on it. But I just really have to emphasize that SRS provides very reliable and very durable tumor control in patients with what we used to consider radioresistant histology to conventional radiation. So it overcomes that by using completely different pathways, and this resistance is really almost obsolete when it comes to when we discuss histology and radiation. So SRS overcomes it. When we looked at over 400 patients that underwent single fraction SRS in the spine, Patients who received 24 gray had a recurrence risk of just over 2% at 3 years. So these control rates are outstanding compared to conventional radiation. And this is regardless of tumor histology, which is very different from conventional radiation. So tumors like melanoma, renal cell, sarcoma, thyroid, all the tumors that are resistant to conventional radiation respond readily to SRS. And the other important point, and this is going to be very important when we talk about the actual surgery that we do for these patients, is that this is irrespective of tumor volume. So we don't have to reduce the tumor volume in order to get good tumor control. We just have to get these patients to SRS safely and get an adequate dose of radiation to these patients. And we're getting this tumor control regardless of histology, regardless of prior radiation, and regardless of their tumor volume, as long as we can get adequate radiation doses. So based on these data and multiple publications that have detailed the safety and efficacy of spinal SRS, the Spinal Oncology Study Group made a strong recommendation that radiosurgery should be considered over conventional fractionated radiotherapy for patients with radioresistant histology. What about the patient that we talked about in the beginning of my talk? This is somebody with high-grade epidural disease secondary to melanoma, which is a radioresistant tumor. This is a patient who needs surgery, and there are two reasons for that. The first reason was provided by the Roy Patchell prospective randomized trial, which looked at patients with spinal cord compression secondary to solid tumor malignancies, and the patients were randomized to either undergo conventional external beam radiation as their only treatment or underwent surgery prior to undergoing conventional radiation. And the difference between the two arms was so drastic that the trial was actually stopped halfway through because the surgical arm did significantly better in terms of ambulation, the duration of ambulation, recovery of ambulation, their continence, use of narcotics, and there was even a slight difference in the survival time. So surgical arm was much better compared to radiation alone. And based on these data and multiple retrospective studies that looked at the outcomes of surgery for patients with spinal metastases, the Spinal Oncology Study Group made a strong recommendation that patients with high-grade spinal cord compression due to solid tumor malignancy undergo surgical decompression and stabilization followed by radiation therapy. The second reason why this patient has to go to surgery is because we know that in order to get tumor control, we have to give SRS to this patient. Conventional external beam radiation is not going to do the trick. And we understand better what kind of dose we have to give to these patients. When we looked at the single fraction failures, the patients who actually had recurrence after single fraction, the only patients that recurred were patients who received less than 15 gray to any point in the tumor. So we know we have to give more than 15 gray to the entire tumor volume, all of it. We can't miss a single point. The only thing that limits our ability to do that is the risk of toxicity to surrounding structures, and of course spinal cord is very important. At our institution we use a maximum point dose of 14 gray to any part of the spinal cord. So if we put these together, we can't give more than 14 gray to the spinal cord, we have to give more than 15 gray to the tumor volume, the entire thing, even the part that's abutting the spinal cord. So the only way we can do that is by providing a separation between the tumor and the spinal cord. And it doesn't have to be a very big separation, it just has to be a couple of millimeters. So once we have that, we can safely deliver 15 gray to the entire tumor volume without risking spinal cord toxicity. And that's the second reason why we take these patients to surgery. And what we've been doing, we've been calling it separation surgery, because what we're doing with the surgery is that's the goal, to provide the separation between the tumor and the spinal cord. We no longer have to resect the vertebral body and the tumor that's in the vertebral body or the paraspinal disease, because we can get tumor control irrespective of volume. So the cytoreductive surgery is no longer necessary. The only thing that we have to do is get these patients safely to SRS. And we do that by reconstituting the thecal sac. Right here, that's the spinal cord, and that's the separation that we have. This is a CT myelogram that we use pretty commonly. All postoperative patients get this for the planning of their postoperative SRS. And as you can see, we leave the paraspinal disease, we'll leave the vertebral body intact even though it's infiltrated by tumor, because we know that SRS is going to take care of it and reconstitute the thecal sac and provide the separation, just a couple of millimeters. Here's another patient. We have some intraoperative pictures from this patient, so it'll illustrate the actual surgical technique when we do separation surgery. This was a patient with dedifferentiated liposarcoma who needed separation surgery and then to undergo postoperative SRS. We usually put the instrumentation first in order to avoid manipulating instrumentation and big things over exposed spinal cord after we do the decompression. The next step is a multi-level laminectomy, and we do that over the areas where there's epidural disease and at least half a level above and below where the tumor is located. And when we go half a level above and below, that really lets us work from normal tissue planes and defining the separation between the ligamentum flavum and the thecal sac and carry the dissection to the tumor levels. We usually use a high-speed matchstick drill in order to do the decompression, because in patients with high-grade epidural disease, there's not much room for the Kerrison foot plate. So drilling the lamina tends to be safer in those patients. And then we carry out a sharp dissection separating the tumor and the ligamentum flavum from the thecal sac. Tenotomy serves as a very helpful in this. And this is the dorsal decompression of the spinal cord. And then we carry out a piecemeal resection of the tumor. We remove the joint in the pedicle in order to gain access to the ventral epidural space, isolate the posterior longitudinal ligament and resect that as well. That allows us to clear the ventral epidural margin and make sure that all the epidural tumor is removed. And once that we've confirmed that clearance using either Woodson dissector or intraoperative ultrasound, that's pretty much the end of the operation. We leave the vertebral body and paraspinal disease intact. And this is the postoperative CT myelogram for that patient. Once again, the thecal sac is fully reconstituted, the vertebral body will leave in place, and the paraspinal tumor is still there. And the patient went on to receive postoperative SRS with a good tumor control. We looked at the results of over 180 patients who underwent separation surgery followed by postoperative SRS. And the overwhelming majority of these patients had radioresistant histology. The few that didn't were previously radiated patients. As you can see, nearly half of these patients underwent some sort of radiation treatment prior to progressing and requiring surgery. And once again, the only thing that really mattered was what kind of dose we're able to get to this tumor. If we were able to get high doses of radiation to the tumor volume, these patients had excellent tumor controls. Single fraction arm was patients that received 24 gray. High dose hyperfractionated, those are patients who were treated with 3 fractions of either 8, 9, or 10 gray. And then the low dose hyperfractionated arm, which is the one that did worse, were patients who received lower than 8 gray per fraction in their postoperative treatment. There was initially a trend towards significance for preoperative radiation therapy, and failing that, but this became completely insignificant when we did multivariate analysis. So the only thing that mattered was the dose. And these are the tumor control rates that we were getting. 1-year local recurrence risk for patients who underwent single fraction SRS was 9%. And it was only 4% for patients who underwent high-dose hyperfractionated radiation therapy. And this is a drastic difference compared to some of the historical publications, which spoke about almost 90 and over 90% recurrence rates for patients who lived long enough to 1 year. So this is a huge difference compared to those publications for patients who underwent conventional postoperative radiation. We also looked at how reliable these posterior constructs are. Since we're not taking out the vertebral body, we tend to use standalone instrumentation in order to restore spinal stability. And these constructs turned out to be very reliable. We looked at over 300 patients who underwent separation surgery with standalone posterior instrumentation. And out of these patients, less than 3% required return to the OR for revision of the hardware for symptomatic hardware failure. And these were largely patients who either had significant chest wall resection or required really long constructs, largely because they had pretty diffuse disease of very poor bone quality. So we spoke about the neurologic and the oncologic considerations. I won't say much about mechanical instability. You're about to hear a great talk from Dr. Shuba, except that I'll just emphasize once again, any mechanically unstable spine needs to be stabilized, and we can't do that with radiation therapy. And then we look at the systemic disease. So we look at the systemic assessment in order to make sure that this is a safe operation for the patient. Part of our systemic staging is to make sure that patients have full spine MRIs, because oftentimes these patients have multifocal spinal metastases. And if you're looking at somebody with, say, mechanical instability and you're treating that, the patient may have high-grade epidural disease in the cervical spine, and you may not know about it because it may not be symptomatic at this time. So we always get routine full spine MRIs for all of these patients. And then we discuss with the medical oncologist whether this is a reasonable patient, and what we're proposing is actually reasonable in the context of what this patient requires. We look at their most recent cancer staging. Oftentimes it's a PET scan, a chest, abdomen, pelvis CT, look at the labs, look at the LFTs, and then we get medical clearance. All of our patients are screened with Dopplers because these are cancer patients who are less mobile because of their spinal disease, and they're very high risk for DVTs, and we often pick up asymptomatic DVTs prior to taking these patients to surgery. And then we'll look at the tumor histology. For certain histologies, epidural disease in the spine is a harbinger of really explosive disease. And while this is a graph from quite a few years ago, these still stand. Colorectal, hormone-resistant prostate, once they become epidural, these patients tend to do quite poorly. So take that into consideration when you're making decisions about how to treat these patients. Once again, just to firm up what I've been talking about on the NOMS paradigm, this is our initial patient. This is melanoma, high-grade epidural disease. This is somebody who needs surgery followed by SRS. On the other hand, if we're looking at the same exact image in a patient with lymphoma, lymphoma is a radiosensitive tumor. This patient has high-grade epidural disease. This is somebody who will do just fine with conventional external beam radiation. The last point I'd like to make, and this is something that we often see in the emergency room, is somebody who does not have a history of cancer, and they may have had back pain, got an MRI, and they come with an unknown primary. And it's a slightly different decision that has to be made because we don't know in which category in the NOMS paradigm these patients are going to fall. The patient has no neurologic deficits, high-grade epidural disease. If we can use the ARS for people to punch in what they would do for this patient. Great. So a lot of people felt that a biopsy was important. Can we switch back to the rest of the talk, please? And I think in this particular patient with no neurologic deficit, they're stable. There's time to do that, as long as it can be done pretty quickly, within a few days or a week max time. Waiting too long is probably not a good idea with somebody with high-grade epidural disease because you don't really know in which category these patients are going to fall. So you can biopsy this, and potentially, if this turns out to be lymphoma, the patient doesn't really need surgery and goes on to conventional radiation without any surgical intervention. On the other hand, if this turns out to be radioresistant, then they'll certainly require surgery. And one more example. This is the same exact image, unknown primary, but this is a different kind of patient. This is somebody who had back pain the day before, went to bed just fine, woke up with leg weakness. So this is somebody in whom we don't particularly have much time to make that decision. Once again, can we use the ARS for this? What would be the first step in treating this patient? Great, yeah, that was easy. Let's go back to the presentation, please. This is somebody who needs surgery because you really want to make sure that you preserve neurologic function or give them the best chance of recovery. Because if they become paralyzed, they're going to be disqualified from a lot of the trials, and a lot of their further therapy is going to be much more difficult for them. So even if you think this is lymphoma but don't know when the patient is deteriorating before your eyes, decompress the patient, you'll get a diagnosis, and they'll be safe. This is an easier one. So just to sum up the entire NOMS paradigm, patients with radiation-sensitive tumors can undergo conventional radiation regardless of the degree of epidural disease. Patients who require stereotactic radiosurgery are patients with a radioresistant disease, and if they don't have cord compression, they can get that up front without surgery. If they have cord compression, they can undergo separation surgery followed by SRS with good tumor control. Patients who have an unstable spine need to be stabilized. Look at the systemic disease. If they can undergo separation surgery, if that's the indication, then they can, and otherwise these patients can go for palliative radiation, which can work as well. So in conclusion, NOMS paradigm integrates modern radiation and surgical options and provides evidence-based guidelines for treatment of metastatic spinal tumors. Spine SRS provides reliable tumor control regardless of tumor histology, volume, and prior radiation, and you'll hear a lot about that tomorrow from some great speakers. Patients with spinal cord compression secondary to solid tumor metastases require surgical decompression, and this can be done with separation surgery followed by SRS. And in patients with progressive neurologic deterioration secondary to spinal cord compression from unknown primaries, save their neurologic function and take them to surgery, and then you can figure out the rest. Thank you.